Hi, good evening, everybody. Welcome back to the webinar. I was away for 3 weeks. I was in Nepal trying to do my summit climb, which I failed, but I had a lot of fun and almost died of mountain sickness. No, like that's an exaggeration. I had mountain sickness, but didn't die. Okay, so welcome back. And I'm glad that we start this talk with my colleague from Sunway. And I see that he really dressed up for the talk with tie and suit and everything. Welcome, Ken. So this is Dr. Ken Tan. Dr. Ken Tan is a colorectal surgeon. Of course, he does general work also, but majoring in colorectal work, right? You do mainly colorectal work, right?
Yeah, general and colorectal lah.
Okay. Yeah. So
okay, you can see my screen?
Yes, can see your screen very well. So I think without further ado, we do the talk. We start first, huh?
Okay.
Okay.
Okay, thank you, Dr. Betty, for the kind introduction. So I feel greatly honored to be given this opportunity to talk about colorectal cancers to all of you. Okay, have a nice evening, everyone. So actually, can everyone see my screen? Can?
Can.
Because now I cannot control my screen. Just give me a minute. Where's my cursor? Okay. Okay. So I understand that the audience consists of doctors and also nurses. So just a brief introductions about general surgery and also colorectal surgery. What is the difference? So in general, colorectal surgery is just part of the general surgery that do everything, just that we have the subspecialty in colorectal. Okay, so today's talk is about colorectal cancers. So before we go into colorectal cancers, I would like to share with you regarding cancers. Cancers for those who doesn't know exactly what cancer is all about. Okay, the cancer, the word itself actually come from a Latin words. It means crab. Crab means it's very ugly looking and a lot of legs and things like that. So it's very ugly looking. So so cancers when it grow into full-blown pictures is always ugly. Okay. So the cancer, the normal cells, when we got a cut in the hand, so the cell will grow back to the same tissue, same type of skin cell and cover up the wound. So the one is normal cells. So the cancer cell means the cell it grow in large number and it doesn't mimic the mother cells and doesn't carry the what the mother cells doesn't carry the functions of the mother cells. So and then it's only continue to grow, continue to invade, continue to destroy the surrounding tissue. So this is the danger about cancer. So in colorectal cancer, so cancer can continue to grow and causing obstruction, a mass causing obstruction in the colonic lumen, and also can cause perforations of the colon, also can cause bleeding when it grow into a larger size. Okay, so this one is the danger about cancer. So it's not normal cell anymore. So there's change in the DNA of the cell that make the cell to be non-functional and also invasive. Okay. So just have a global pictures about the incidence of cancers. So it's about 18 million a year, and then almost half is happening in Asia.
Oh, why so big, the number?
Yeah. So this one is from the cancer statistics in 2017. So this one for the whole world. So actually the half of the populations are actually half of the global population actually in Asia. So it's quite consistent with the cancer incidence.
So Asians have the highest number of cancer.
This one is a percentage, and it means almost half of all the cancer, new cancer incidences, actually half of them happen in Asia. Of the new cases every year, yeah.
Is there any reason why it's so rampant in Asians compared to every other country? African only 5.8.
Yeah, this one is the total. It means they say 18 millions of the new cancer every year. Almost 9 million happen in Asia.
Okay.
almost half happen in Asia. So because actually half of the populations of the global population on Earth actually is in
In
Asia.
Asia.
Yes. So it's
Oh,
consistent.
I see. It's
Okay.
okay. It is not like the prevalence of the cancer.
No, it's incidence. Number
Oh,
of new cases
okay,
of
I
cancer.
understand.
Yeah,
Okay.
yeah.
Okay.
Okay. This one just have a rough idea. Okay.
Yes, that's right.
Okay. So this one, so based on these statistics from Ministry of Health, almost 1 in 4 people, when we reach the age of 70 years old, almost 1 in 4 people will get cancers, any type of cancers.
One
And
in four. Okay.
yeah, 1 in 4. It means when we age, so aging is one of the major risk factor to get cancers. So if everybody is long life enough, eventually it's not uncommon for us to end up with cancer lah.
Yes.
Yeah, okay. Dr. Betty, can I just ask you, on my screen, there's this box, but I cannot get rid of this box.
Which box is that?
We
Don't
say
see.
that this meeting is being recorded by the host or participant. So this one,
Yes. I'm recording it.
so how can I get rid of the box?
Which
It's
box?
at the center. This thing is at the center of my screen.
Oh, that's the sensor. Okay, I
Ah.
think you click it. Are you using a MacBook?
Yes.
Okay, you click on the right hand corner, on your left hand.
Okay. I settle.
Okay,
Thank
settle.
you. Okay. So then, regarding cancer in Malaysia, so slightly more in females lah. You can see the ratio is 1 to 1.2.
Mm-hmm.
This contributed to breast cancer,
Yes, because of
I
breast.
think.
Yes.
Yes. And the 5 top cancers in Malaysia, colorectal is number 2 lah. First is breast. This one is combining the both sexes, the both genders. Okay. So if we go cancers by
Very
any group,
common, huh?
yeah, if we go cancers by any group, predominantly among Chinese, compared with Malay and Indians. Okay. Okay. So cancers in Malaysia is quite interesting. And you can see the states dominated by Chinese one have the highest incidence of colorectal cancers.
Oh, okay.
Not only
Chinese,
colorectal cancers, all type cancers.
even NPC also highest in Chinese.
Yes. And colorectal cancers also.
Oh,
Okay. So as you can see, the states, Pulau Pinang is dominated by Chinese. The incidence of cancers also is the highest among the state. Actually, I got the incidence for every state, but I think I don't put it in. Okay. So this one is the statistics for the 5 years, 2007 and to 2011, these 5 years. Is a similar with the latest 5 years, which is 2012 to 2016. So that means for the past 10 years is the same. So colorectal cancers is the number 2nd for our population, second commonest cancer. But then if we look at the individual gender, male and female, so colorectal cancer is number 1 killer in men.
Oh.
Second in female. It used to be a lung cancer number 1 in men.
Yes.
As a smoker getting less and less, so now colorectal cancers went
It's
up to
okay.
yeah,
Oh,
it's been become number 1 for the past 10 years.
yes, smokers, I see that smokers are getting less. Yes,
Yeah.
it's a good news.
But then the incidence of heart disease is not going down, right?
Phew, thank God. Now I've got no job.
Okay, so it's the same for the past 10 years. So this one is for 2007 to 2011. So still the same for 2012 to 2016. So this one past 10 years, still the same pattern. So number 1 killer in men, colorectal cancers. Okay, so this one, we look at the colorectal cancers in Malaysia. We just want to focus on this. Here you can see my cursor. Okay, the male and female, can you see? Male, female, male 14.6 per 100,000. Female 11.1. Can you just remember these two figures? 14.6, 11.1. Okay, so incidence highest among Chinese compared with Malay and Indian. Let's look at our neighboring country, Singapore. So 14.6, 11.1, still can remember? So 14.6, you see, in Singapore is 39.6 per 100,000. No. Ours on 14.6. Oh. And Singapore female colorectal cancers are 27.6. Just now ours one 11.1.
Why they're so high? Because they're all Chinese.
Yes. So this one, no need to see file, we just see our Singapore registry. So either our Malaysia registry is not full reflections, maybe they didn't report all the cancers up, or some of the patient didn't go to hospital, or because of the Singapore is a Chinese dominated countries. As you can see, it's
So
very
in
obvious, right?
China, how about in China? They're all Chinese.
Yeah.
So
Yeah, so
colorectal cancer must be very high there.
yeah, but sorry, I don't have the data to show you to here. But I
Oh.
just show, okay, our male 14.6, predominantly Chinese, female 11.1 per 100,000. So maybe our statistics has been diluted by other races. Because as we know, the Indians and Malays have lower rate. So this one per 100,000 inclusive of other races. So our statistics is being diluted by other races.
Possible.
And then, yeah, in Singapore, it's high because their whole populations are 70% are Chinese. Okay?
Okay.
Okay. So what is colorectal cancers? So colorectal cancer is very simple. Cancer that happen in colon or rectum lah. Oh, okay. So these are the ugly pictures the true pictures that I took out from the patients. This one not the Google photo or anything.
Oh
So
my.
as you can see, yeah, all these ugly looking, as I told you, cancer come from the Latin word, it means crab. So you can see it can cause a mass-like lesion. Here, you all can't see my cursor, okay. So you can see it can cause lesion, can cause invasion, ulcerative lesion invading to a bladder in front. So we are moving at the top row, third one. Then we can see causing perforation, causing polypoidal mass, causing obstruction. You can see these are the cancers. Okay, so you can see this cancer mass already grow out from the anus.
Oh my God.
This one is very, very, very smelly. Until the wife also had to leave him because it's too smelly.
I think we can reduce that. Okay, go on.
Okay. Okay, so this one is one examples of cancers causing obstruction. You can see the obstruction point is at the near the hepatic fracture, or we call proximal transverse colon there. So you can see approximately the cecum ascending colon is all fully dilated up to the terminal ileum. So this one is an example of obstruction causing by colon cancer. So you can see the caliber of the colon is different, proximal and distally to the cancers because of dilatation in the obstruction. Okay, then you can see one side got stool, the other side have no stool. There's obstruction by the cancers. Okay, so these are the cancer cell arising from the internal linings of the colon. So it doesn't have any more functions of the normal colon inner lining cells normal functions. So it's just cancer growth. So with the altered DNA, it will continue to grow until obstruction, bleedings, or perforations. Okay, if we don't take it out, then of course it can spread to distantly to other organ. Okay. So these are examples in other cancers. So examples, okay. So this one you can see also stenotic, and these are then obstructive, and so spread to the adjacent lymph nodes. Okay, this one is causing peritoneal spread. Okay. Okay. So can I? Okay, let's have a more interactive session rather than everybody listen to me. Okay, so you can see, can we have a lab guess? You think the colorectal cancer is more on the left, colon cancer more on the left or right?
Okay.
Anyone
Anyone?
want to try? 50%, a toss of coin. Left or right?
I think it's more over the left.
Yeah, if you look at the answers, it's already on the photo here.
That's because of the
Again here.
75%.
Yeah. Then have you ever thought why is it more common on the left?
No, I didn't know it was more common until
Yeah. Oh,
But
the
why
reason
is
is
it more
very
common on
simple.
the left?
The reason is very simple.
Hmm?
Because you know the small bowel hardly get cancers because our food is
Hmm?
in liquid state in the small intestine.
Okay.
So always so when the stool enter the from terminal ileum enter the ascending colon and cecum, so it's still liquid. Then after that come to transverse colon semi solid. Then go to the left side become solid.
Oh, I see.
So when it become more solid, it will transit more slowly,
Hmm?
more contact with the
Vicus.
colonic wall,
Uh-huh.
then more likely to stimulate the cell DNA alterations and mutation and causing the cell to transform into cancerous cell. So with those patients, they say you got constipation, so the contact of solid stool with the inner linings of the colon is longer. So most likely to stimulate polyp formation. Then after that, the polyp will eventually grow bigger and bigger and turn into cancers one day. Does it make sense?
Yes, it does
Oh,
make sense.
yeah. Okay.
But
So
the
this,
Chinese part don't make sense.
which one?
Chinese part, the Chinese, the genetic part of that. Okay, later we will discuss that. Okay.
Yeah. Okay, later we come to the risk factor of colorectal
Yes.
cancer.
Okay.
Okay. Why my slide can move already? Jam already. All button jam up.
Are you sure?
Uh, is
You
my computer problems or what?
press
Sorry,
down and up,
what
the
happened?
up and down button.
Up and down,
Yeah, up
cannot.
and cannot.
Cannot. Right also cannot. Just now I use left and right, okay. But now it's like hanging.
Uh, okay. Go up, up, up,
Up,
up.
down.
View option. Oh no, up and okay. Unshare and stop share and do again.
Still
Yeah.
doesn't move. How to move to the next slide? How to move to the next slide?
Okay, you just now what do you do?
Just now I use the left and right button, but now doesn't seem to work anymore.
Okay, you slide your pad, slide it, slide your pad. You see your middle pad below your keyboard.
Yeah, okay, already. Okay. Thanks. Okay, so what are the warning signs of colorectal cancers? Okay, so this one is very simple if you know the consistency of the stool. As we know, the left side is more solid. Am I right?
Yes.
Right side is more semi-solid. Oh, so that's why the left-sided colorectal the left-sided colon cancer or the rectal cancer is more, the symptom is more to what we call it, the physical stool I mean the physical stool of the left-sided colon or rectum. For example, if we have left side,
Sorry.
me?
Yeah.
Hello.
Don't worry. Somebody just
Okay. So for left-sided colon cancer, because it's nearer to the anus, so when the cancer bleed, you can see bright red color. Okay, so left-sided because very near to anus locations. Okay, so because the stool over the left side is more solid, so any cancer causing narrowing of the lumen can cause constipation or slimming of stool.
Okay.
But then the right-sided, because the stool is more semi-solid, so it seldom present with obstruction. So they always the right-sided.
Can I ask you this question? Does the left-sided colorectal cancer present earlier than the right side?
Yes, you can say that because the right-sided, because they seldom present with obstruction, and because the stool is always in liquid or semi-solid the most, so it seldom present with obstruction, and they always present late. They present with a mass or with anemia. the right-sided colon, and you don't see blood with your naked eyes. You get what I mean? So the right side always present late because they can't see blood.
Okay.
There's no obstruction symptom. They
Oh,
will come with a mass or anemia.
okay.
Then the left side one, you can see blood. Then the stool is slimmer. You can see, oh, last time your stools tend to be very bulky. Now it becomes slim already. Okay. Then or other systemic symptoms like weight loss, weight loss or the abdominal pain, these sort of things. Okay. So when you have any auto bowel habit, you have to watch out lah.
Okay.
So when the lumen become very, very small, so it will cause a diarrhea. Diarrhea, or we call spurious diarrhea. Spurious diarrhea means it's a false diarrhea, it's not true diarrhea. Because the stool had to become liquid in order to overcome the obstruction. Okay, so any auto bowel habits, you have to watch out. So these are the symptoms. Okay, next. Okay, so just want to, if you want to know rectal cancer a little bit more, we need to know a little bit about the anatomy. You look at the male, the front part of the rectum is a bladder, prostate, correct? So the front part of the female, so it's a uterus, vagina, then in front of the uterus vagina is the urinary bladder, correct? So when rectal cancer invade the neighbor organ, so in male, it can invade into prostate or bladder. So in female, it can invade into the vagina, causing rectal vagina fistula, can invade into the uterus. If that happen, so then we need to take out the cancers together with the adjacent neighbor, the neighbor organ. Okay. So okay, so when you have blood in the stool, are you worried? I think of course everybody will be worried lah. So are they always means it's colorectal cancers? They are scary, but not necessarily colorectal cancers. There are many causes of blood in stool. So these are the example of causes. The most common causes is still the benign causes lah. For example, the hemorrhoids, diverticular bleeds, fissures, or angiodysplasia, or trauma from anal sex, or patients having gastroenteritis or large polyp, okay, or IBD, or patient on anticoagulant drugs given by, or maybe cardiologists, or the antiplatelet. Okay, so these are the other causes apart from colorectal cancers. So so important thing is when you have blood in stool, is to have a peace of mind, better to go and check up lah, or see your doctors, see whether you have any other possible causes or not. Okay, so we come to risk factor for colorectal cancers. The most important risk factor is a polyps formations in the colon. So we believe that from all 95% of the colorectal cancers come from polyps. So the polyps, it will take for a few mutation for it to become a colorectal cancers lah. So an average you take about 10 years, at least 10 years lah. So if we catch a polyp at the polyp state and we remove the polyp, then it means you have no chance to, the polyp have no chance to grow into bigger polyp and no chance to grow into cancers. And that's how we can prevent colorectal cancers, by removing all the polyps that we see during the scopes.
And how
Okay.
prevalent is this polyp?
Okay, this polyp
Huh?
increases with age. The more advancing age we are, the more likely we have age. The more likely we will have polyps in our colon or rectum. That's why we later on we will come to screening and what's the recommended age for screening scopes. So we actually recommend at the age of 45. Okay. So most important risk factor is polyp. Okay. Then after that, if we divide the risk factor into two broad topics, modifiable and non-modifiable. So non-modifiable, for example, everybody is aging, they want to become modified. If I'm born Chinese, I can modify my genetics. Okay. So if I have family history of colorectal cancers, I can modify. I can change my parents, correct? So so these are the non-modifiable factors. The modifiable one, for example, exercise, healthy lifestyle, avoid smoking, reduce in fat in diets, so doing the scopes and removing polyps. So all these are the modifiable factors. Okay. Okay. So move to the next one. macam mana?
Oh, endometrial cancer less than 50 years old is a risk factor for colon cancer.
Yes, actually, any cancers with onset of less than 50 years old, we consider this one as young cancer. Young cancer, so in Lynch syndrome, it means if they have cancers of stomach, ovarian, endometrium, breast, colon, so all these cancer involve 2 generations, and also both also less than 50 years old. So this one we classify them under Lynch syndrome.
What do you
So
mean?
this
You mean like, okay, let's say me, I had endometrial cancer in my 40s. And is it a risk factor for colon cancer?
So if you have other family member in your family tree who also got other type of cancer, either stomach, esophagus, breast, ovary, or endometrium or colorectal. So this cancer, less than 50 years old, involving 2 generations, then you are high risk. It means there's a
Oh,
chance
you
that
mean
you
not
will
me in
having.
itself lah, not me in itself lah.
Yes. It
Yes,
means
but
you
I have
look
family
into it.
history with all those cancers. Oh,
Wow. Also, you have to check for, in the case, then you have to check for the Lynch syndrome. If you
what's
carry the Lynch syndrome, Lynch.
LYNCH?
So Lynch syndrome, if you have the genes, then you pass it to children, then you tend to have high risk for developing early cancers at the age of less than 50.
Necessary.
So in patient with this kind of history, so patient with this sort of history, then they are high risk for the colorectal cancers.
Okay, I will look it up.
Okay.
Okay.
Okay. So I move to the next slide. Good. Okay. So actually, most of cancer happens sporadically, sporadic cancers. That means 3/4 is sporadic. Only 25% are carry family history. This is why a lot of patients say, hey, I have no family history, how come I can get cancers? Okay. So this is what I say about the polyps. So you can see the polyp, it takes about 10 years to slowly, small polyp will grow into large polyp and eventually turn to cancer. Okay, this is an example of polyp. Okay, so these are the different type. You can see the cancer the cancer features will become more apparent when it become larger. So you can see a larger one, it looks more ugly. So there's more nearer to cancer. Okay. And so as for most of the cancers, we have screening program. So why do we have to screen? Because the colorectal cancer is preventable, and also when we detect early, it's treatable, and 90% of all the colorectal cancers are curable, if we detect it early. So that's why screening is very important. Okay, so what are the screening method that we have for colorectal cancers? So the cheapest, the most easily accessible one will be the fecal occult blood test. Second is CT coronography, and third is colonoscopy. Okay, so fecal occult blood test, actually our government offer free for those more than 60 years old in the clinic kesihatan. So you have to do this test. If positive, means you contain occult blood. So when you can see, naked eye can see the bright red blood, then you no need to do this test. This one is to detect occult blood. Our naked eye cannot see. So we can detect blood. So it could be, so there's a possibility that you're having a large polyp or you're having a tumor, colorectal tumor or cancers that shed out blood. But
How
then,
often should you do this test?
Okay, this one we recommend 3 times in a year.
Oh,
3
okay.
times in a year. So if 3 times negative, then you repeat next year. So
Okay.
if any of the 3 times positive, if 1 out of 3 positive, then we recommend the patient to go for colonoscopy. You get what I mean? Okay. So because not all the time when you are doing the fecal occult blood test, that the tumor or the large polyp shed out blood. So it may not shed out blood at the time of the test. That's why you have to do 3 times.
Oh, you do 3 consecutive times.
3 times separate occasion.
But what is the duration between these 3 times? Doesn't matter.
So there's no fixed duration. It's like we don't know when the tumor will shed out blood.
Okay.
So that means we
So
do
it's
3 times.
random lah. It's random.
Yeah, random. So it's 3 times. We just want to make sure 3 times negative, then unlikely you're having cancers. So this is a very cheap test, easily accessible, well accepted, and also most of our GP friends can do it for our patients. So if the patient not keen for colonoscopy, as you know, the colonoscopy is more invasive, more expensive, need to go to hospital. Okay. Okay, so this one CT coronography is more famous in the overseas, especially in like US or UK. They usually recommend this one for the elderly patients. So as you can see the photos, they can pick up the polyps shaped like this, and this one is a corresponding photos in the colonoscopy. Okay. But then the only drawback is when you detect polyp, you can't take out. So not like colonoscopy, you can see and you can take out straight away. So it's like another work, no, double work. So
Okay.
they only recommend it for elderly patients. For example, 85 not suitable for colonoscopy, so they go for this CT coronography. Okay, so then people may misunderstand that CT coronography actually no pain, no bowel prep, no risk. It's not true, It's not true. So the CT coronography we do using the high-speed CT scan, we can do it. But then the patient still need to do bowel prep, and then during the process, they have to instill this gas, through the rectal tube, and the patient with no sedation, patient will still feel the discomfort. Sometimes can be worse than the colonoscopy. And the full bowel prep is needed. The profession risk is still 0.05%. The profession risk in colonoscopy is about 0.02%.
Oh.
Less. Yeah. So that's why it's not so popular in Malaysia. But in overseas, they only do it for, so they do it for elderly patients, those who are not keen for colonoscopy. Okay. Cheaper, maybe it's a bit cheaper by radiologists. Okay. Okay, so this paper from New England Journal of Medicine. So it just want to show that so for CT coronography, the pickup rate is similar to the colonoscopy when the polyp is more than 10 or equal to 10 mm. You get what I mean? If the polyp is smaller than that, CT coronography is inferior to colonoscopy. Okay, so looks like the CT coronography not so good, right? Compared with the virtual, the actual colonoscopy. So this one is the example of colonoscopy. You can see the scope have the camera and the channel for irrigations and also light. Okay, so this is an example of scopes. So usually we pass the scope through the anus, go to rectum, then all the way to sigmoid colon, descending colon, transverse colon, ascending colon to cecum, and also to terminal ileum. Okay, so we pass through the whole length. Okay, so poor bowel prep will increase the chances of missed lesions, because we can't see. When the visibility is low, it's like having fogs or haze. We can't see through, so we miss the polyp. So if we miss a polyp, then there's chance that polyp may grow into cancers. Okay, so it's very important to have proper bowel prep before the scope, before procedure. Okay, so of course the colonoscopy is operator dependence. So if the doctor very busy, very fast in, fast out, there's a chance of missing lesions. So the study show we recommend withdrawal of scopes at least 8 minutes or more. Otherwise, there's chances of missing lesion. Okay. Okay. So when do you do the scopes? So the guideline says you have the scope immediately if you have those warning signs of colorectal cancers. If you don't have any symptoms, then we recommend, in the old days, we recommend the age of 50 years old. With the increasing, we are seeing increasing young cancers nowadays. So now we recommend for age of 45 now, instead of 50 years old. Okay, so no symptom, 45, have your first scope. If your scope normal, you can have peace of mind of 10 years, because we know that polyp to cancer take about 10 years.
Oh, I
If you
see.
have symptoms, if you have symptoms, you scope immediately, because my younger cancer is my younger cancer is 20 years old. So from the literature, the younger cancer is 16 years old. Okay, so doesn't mean you are young, you cannot get cancer. Okay. Okay, so how to manage the colorectal cancers? First, we must diagnose first. Then we stage the cancer. Then we assess the patient's fitness for surgery or for chemo or radiotherapy, or see feasibility of operating on the cancer, things like that. So diagnose, stage, and assess. Sounds simple, right? Okay. Okay, diagnosis, usually we need a HPE lah. We need the histological diagnosis, need biopsy. Okay, so this one need to be done through the colonoscopy. Okay, so when the polyp get bigger, then there's a chance of spread to lymph nodes and also distant organ, because the invasion will be deeper. Can you see from these photos? So the management is very largely dependent on what stage you detect the tumor. Okay, so at the early stage, actually, you can totally remove through endoscopy procedure. For example, this one. Okay, so we can do polypectomy, or we can do endoscopic mucosal resection, or we can do endoscopic submucosal dissection. The purpose is just to remove the lesion that we detect, because the polyp not necessarily come with the pedunculated with the neck. Some can be sessile, means flat. Some can be just a little bit elevated. Okay. So these are the example of polypectomy you can see. So this one with the neck lah. So you can see large polyp. You can see this bowel prep is very clean. So there's no stool there. So we just use an instrument. This instrument we call it loop snare, hot snare. Hot snare. So we'll run the electricity through the hot snare. Then it will burn and cut
Oh,
the
it's like
polyp and then
cauterization?
yes, correct. So this one we call hot snare polypectomy. So there's another type of snare we call cold snare. So the ones without heat and without the electricity. So this one is hot snare. So after we cut it, so there's no bleeding from the stalk, then we can either retrieve the specimen directly, or we use a netting. Okay.
Yeah, I want to ask you, for example, this patient only has one polyp. So you have taken off the polyp. What are the chances of him having recurrent polyp eventually?
Okay, so depends on the histology of these polyps.
Okay.
Then we will advise the patient when to operate the scope. If
Oh,
this
when
polyp, if this patient polyp is a high-grade dysplasia, and the margin is clear, it means it's cured already by removing the polyp. If the margin involved, then we have to go in to remove again, because high-grade dysplasia is almost equal to carcinoma in situ. So if the patient is low-grade dysplasia, so this procedure itself is enough. We advise patient to repeat the scope in 3 to 5 years.
Okay.
If the patients have hypoplastic polyp, then we ask patient to repeat in 5 to 10 years. Okay. So this one is the for flat polyp. We actually inject first to raise it up, raise up the lesion. Then only we put the hot snare over.
So this is like covering the surface of it doesn't grow outward like a mushroom, right?
Okay, I think we due to time factor, we move on. Okay, so staging, usually we use the NM staging. So based on staging, is very simple. So you look at this one, stage 1, 2, 3, 4. Okay, so when there's a spread to distant organ, it's stage 4 straight away. You can see the M. T means the tumor invasion. N is lymph nodes. The M, McDonald M, big M is metastasis. So when they spread to distant organs, straight away stage 4, either A or B lah. Okay. Then you can see stage 1 and 2, there is no lymph node involvement at all. The moment lymph node is involved, cancer spread to lymph node, stage 3 at least. Okay. So it's that simple. Stage 1, 2, 3, 4. So when there's lymph node involved, stage 3 at least. Okay. So when they spread to distant organ like liver or lungs, then stage 4 straight away. 1 and 2, no spread to lymph nodes, no spread to distant organ. So then only Depends on the how deep it invade the bowel wall. For example, you look at this one, this one is bowel wall. You can see the mucosa is the inner lining of the colon. Then after that, got some mucosa, got muscles, then up the outer layer serosa. So if T1 means up to some mucosa, T2 up to the muscle, something like that. Okay. So this one is T. So N is number of lymph nodes harboring the cancers. So when you're having more cancers, more lymph nodes in the harboring the cancers, it means your end stage become higher. The other one spread lor. Once you spread to a distant organ, consider for metastasis. Okay. So we diagnose with stage already. Now we come to prognosis. Is everyone okay?
Yes.
Okay.
Yes.
Hello.
Yeah. Why?
Too boring to talk. So sorry.
No, it's
Okay.
okay.
So
Don't worry.
can you hear me?
Can, of course.
Okay. So how's the prognosis for colon cancer or rectal cancer? Do you think which one's better prognosis?
Colon.
Okay. Yeah, okay. Yes. Dr. Betty, you're right. Very, very smart. Okay, colon cancer better. Why? Any idea?
Because rectal cancer is the margin tend to be difficult one to operate. If possible.
Okay. So is this one something to do with the lymph nodes? Lymph nodes,
Oh, lymph node.
Okay, lymph nodes. You look at the rectal cancer, especially the low rectal cancers. The low rectal cancer, it can spread both lymphatic system. One they follow the we call inferior mesenteric versus the one on top of the rectosigmoid junction there. Then the other way is through the lateral pelvic side wall going to the ilia nodes. So during operation, we always clear the one with the inferior mesenteric versus the one on top. The one embedded on the pelvic side wall, we don't routinely clear it. We use radiotherapy to shine it. So if we left any cancer cell, any cancer harboring lymph node at the lateral wall, so it tend to recur. So only rectal cancers need radiotherapy, whereas colon cancer never, no need to use radiotherapy, only chemo only. That's why you know how complicated the rectal cancer is lah. So look at this one, the pelvic side wall, the ilia nodes there. So these are the place where the rectal cancer can go to the either left or right side pelvic nodes, can also go to the inferior mesenteric versus nodes. Okay. So then for other cancer like this, okay, you look at this one, the left photos for colon cancer. Can you see the photos? So lymph nodes just follow the only one way, only follow the main blood vessels only. So that's why we have this left hemicolectomy, right hemicolectomy, anterior section kind of things. So it's follow there's no other different type of lymphatic pathway. So for rectal cancer, there are two pathway. Okay, so it's more difficult to clear. So as you know, the cancer surgery is not only cutting out the cancers, but the main thing is still the lymphatic clearance. Okay, so we diagnose with stage, then we assess the patient fitness. If the patient is like very old, bed bound, then you found out that she has cancer. So this kind of patient is not fit for surgery. So if the cancers is invaded into bladder and prostate, so you must see whether patient is it fit for this, what we call that, pelvic accentuation, because you take out the rectal cancer together with the prostate and the bladder. Okay, is it feasible to take it out, things like that. So the mainstay of treatment still surgery lah. So other oncological treatments means either chemo or radiotherapy. Okay, so the main pillar of treatment still surgery, either before surgery straight followed by the onco treatment, or onco first. Usually for rectal cancers, onco first, and then only we do surgery. Okay, then for surgery we have lab, open, and robotics lah. Okay, so the main goal of surgery treatment is to achieve local control, long-term survival, preserve the anal sphincter, preserve the bladder function and also sexual function, improve and maintain the quality of life. It means try to avoid stoma if possible. So I mean, the purpose of having colorectal surgeon is to tackle difficult case. For example, maybe some of the difficult cases, general surgeon cannot preserve the anal sphincter. So colorectal surgeon can. in certain extent. Maybe we can do intersphincter resection to preserve the sphincter, something like that. Okay. Okay, so the surgery, so minimal invasive surgery. So what we know as either laparoscopic or we call it robotics. Okay, so I'll tell you the different short while. So this one is called laparoscopic. Laparoscopic minimal invasive surgery, it produces a very, very small scar. Sometimes if the rectal cancer, we can just retrieve the specimen through the rectum. Okay. So sometimes we can retrieve the specimen through the center of the belly. Okay, center of the abdomen, then a small scar. So minimal invasive surgery has proven so reduce blood loss, quicker return to work, quicker discharge, shorter stay. So just that it just take longer operating time, that's all. So otherwise it's very good. So reduce the scar, cosmetically better, less pain, so less risk of pneumonia in elderly patients. Okay, so in these patients, so you can see he got this the left-sided colon cancer. So the cancer is stage 1, so quite early. So we don't feel the bulky tumor, so we had to tattoo it, tattoo the colon before we do the resection. Okay, so you can see the scar. Okay, one of the scar over the right side, the one is a patient old appendicectomy scar, not our surgical scar. So the actual scar is very small only. So we retrieve the specimen through the center of the
Why
belly.
didn't
Okay,
you
we
put
call
it through
belly
the
button here.
appendicectomy scar? Then got one less scar. You should have cut at the appendicectomy scar.
The appendectomy scar was very hard was done in Indonesia. Okay, then this patient's friends who is actually this patient actually is a Indonesian. So his friend so he flew out from Indonesia to Malaysia for treatment, and his next bed patients in Indonesia stay back in Indonesia and did the surgery. So this is what the open surgery and in Indonesia, and also they put a stoma for him. So then this patient also end up with a wound infection. So so the patient say, oh, thank God he flew out from Indonesia and have treatment in
I
Malaysia.
cannot compare lah. Maybe he has more extensive disease.
According to
Yeah, you
this
cannot.
it's same stage, I'm not sure. So okay, so I mean if we have longer scar, then if the ones are wound infected, then you delay your time for chemotherapy lah. Okay, then okay, so these are the other examples of we call minimal invasive surgery. You can see the scar very small. Okay, so these are the specimen that we take out. So you can see all these scar it's very small. Okay, so sometimes when the patient have gallstones, we can take out together with the cancers. So this patient require a small ileostomy stoma. Okay,
So
so
many
this one
gallstones.
yeah. Because gallstone. So the advantage of doing laparoscopic surgery is we can use the same scar to take out other sites. For example, we can take out appendix, we can take out the gallbladder and things like that, without creating extra scar. Okay. So these are the examples of specimen taken out of a patient. The rectal cancer post radiotherapy, it looks a bit stiffened. So this one also undergone laparoscopic surgery. You can see the scar is all very small, and this one is stoma left-sided. Okay, so this one is a rectal cancers. You can see stenotic lesions at the center of the rectum. Here is a front view anterior. The other is the posterior view. You can see the TME, the very nice mesorectum. So these are the qualities of specimen that we want from any type of cancer surgery, rectal cancer surgery. And you can see the special things about the stones. The stone, the gallstone in the gallbladder actually is like crusted up. Can you see? So this gallstone is very,
Cannot
very,
take
very
out gallstones lah. You are colorectal surgeon.
no, the patient so happen that so happen to have a gallstone together. So without creating a scar, extra scar we can take out together. So kill two birds with one stone. Okay. So this patient also got the very small scars and stoma. So most of the patient they don't have stoma. Okay, certain patient, very low rectal cancer, we advise to have stoma. Okay, so you can see this patient previously got the vertical, I think it's an old cesarean scar. So actually, so we use back the old scar here there to retrieve the specimen. Okay. Okay, so you can see another examples. We always retrieve through uh the
How
belly
do you
button here.
extract such
Okay.
big volume, big masses from such small scar? You morcellate them.
So this one is our secret. This is our secret,
Morcellation.
our secret weapon.
I thought you morcellate them.
No, no, I didn't. We
You
take
don't
out in one
morcellate them,
piece.
ah?
You can see these are the specimen that we take out one piece.
Oh
This one we
yeah,
take
you
a
can
photo
take one
outside.
piece. How,
Yeah, we take out a photo outside. Oh, these are outside, you can see.
Yes, yes.
We never morcellate. The pathologists will kill us because they can never get this histological T staging and N staging. So
How do you
we
take
could
it out
never.
with a small scar?
Ah,
Okay,
yeah.
one
So
day you tell
you
me.
must look for colorectal surgeon. Okay, just want to show you this patient done it 4 years ago. Can you find a scar? Young lady. So these are the effect that we want. Can still wear bikini. Correct.
Who cares about scar? I got scar, so I wear bikini lah.
Okay,
I got a huge scar.
yeah, after a few years, you hardly see the scar.
Yes,
Okay.
true.
Okay, so you can see. So as I told you, my younger patients was 20 years old, and my older patient is this patient 95 years old. This one after he come with the obstructed rectal sigmoid cancers. So I told the wife also 95 years old. I said, so old lah, just do stoma, no need to take out cancers. Then the wife said, no, I want my husband to live another 3 years. You please take out the tumor. So after explaining all the possible risks, no, they are willing to take high risk, so we go ahead. And the patient pull through. 1 week later, he go back to his farm. I mean, he got a small farm in front of his
Oh my
house and he
God,
planted
90
vegetables. Yeah, 95.
still can farm
95.
all young.
Yeah, 95 years old. So he undergone this laparoscopic surgery, recover well. And he wanted chemotherapy. Just that he went to see a few oncologists, no one dared to give him chemotherapy. They all say, uncle, go back and enjoy life. Yeah, because the chemotherapy carry risk, you see.
Well
Okay.
done.
So the minimal invasive surgery really changed a lot in our surgical practice. Okay. So the patient also recover faster, can pull through better. Okay, so this one is examples of laparoscopic and robotic. Actually, the scar is the same, just that the one is a human arm assisting, the other one is robotic arm. Can you see?
Yes.
So which one would you prefer? If you want to pay more, you have to you want to robotic, then you have to pay more lah, because insurance only cover for laparoscopic
Oh,
so
I
far.
see. Don't go for robotic.
So you have to pay extra 10 to 15,000, depends on what procedure you have.
I see.
Okay.
Okay, we need to summarize and
Okay, summarize
because
now.
we have
Take
some
home message.
questions.
Okay, take home message is
message.
incidence of colorectal cancer is on the rise. So we can do something on the modifiable factor. Maintaining healthy lifestyle, eat right, exercise, avoid smoking, alcohol. So screening save life. So early colorectal cancers are curable. So advances in treatment have led to very good survivors in colorectal cancers. Okay. So prevention is better than cure, and screening save life. Thank you everybody for
Thank you
your
so much.
attention.
And I think the even on the oncology side, the treatment is also now colorectal cancer is curable, right? I think I read.
Stage 1, 2, 3. Stage 1, 2, 3. If no, we will surveillance after operation and oncological treatment. We surveillance after 5 years. If no recurrence after 5 years, consider cure.
Oh, I see. Okay.
Okay, that means
we
we'll
have
follow
some
up.
questions.
Yes, 5 years.
Dr. Siti from Doquity asked, is it most Chinese drink some herbal tea so they have no constipation? No, I don't drink herbal tea at all. I'm not sure about other. I think Chinese tea is not exactly herbal tea, but then But Chinese has a high incidence of colon cancer, so the tea has got nothing to do with it. Okay, Kevin Lee from Facebook asked, is there a carcinogenic potential of SARS-CoV spike protein and turbo cancer genesis? Do you know?
COVID.
Yeah, I don't know.
Actually, we know that virus is etiology for nasopharyngeal cancer lah. But then for colorectal cancers, we don't have established data on any particular virus can cause colorectal cancers lah.
Okay.
So COVID is we just is a new virus. We don't know. We don't have any data on that.
Okay. Dr. Dang from Kodokriti asked, is this a very good question because the use of long-term aspirin, does it reduce the risk of colorectal cancer recurrence or even colorectal cancer at all?
Yes, is does reduce in those with IBD. You know that the inflammatory bowel disease got two types, right? So ulcerative colitis and Crohn's disease. And which one is more prone for colorectal cancers? Is ulcerative colitis. So studies show that if you have long-term use of aspirin, because so it can reduce the inflammation. So all these because of the chronic inflammation is the one that leading to cancer formation in IBD. So by using aspirin can reduce and prevent
And is
or
this
delay the
low
onset
dose
of cancer.
aspirin? Is this low dose aspirin?
Yes, 75 milligram.
Okay. Dr. Jasper asked, I would like to share this. I'm a 27-year-old stage 3 sickle cancer survivor, and the symptoms he had was very vague, severe lethargy and weight loss. I had fistulectomy and herniaplasty done under Dr. Oh, Dr. Tan, that's you. You did it for him.
Oh. Oh.
And did not have a chance for a right hemicolectomy. Oh, I hope you're well now, Dr. Jasper. Are you okay? Okay, Dr. Siti, okay, there's a gentleman from Facebook that says, Dr. Tan and Dr. Betty, could I inquire about diet for colon cancer survivor? My father had 20 cm of his colon removed in October 2020 due to colon cancer, stage 0. He was advised to go on blended organic diet due to reduced absorption. He is 76 years old this year and yearly colonoscopy has been normal.
Okay. Okay, so actually stage 0. Stage 0 means not even cancer, is it? So
Right.
actually from stage 0 means it's a carcinoma in situ, maybe it's just high-grade dysplasia. So it's not considered cancer yet. For colorectal cancers, we must has histological proven invasion into submucosa, then we call it stage 1 cancer. So if just carcinoma in situ, so that's why they call stage 0 lah. So that means the father is not even having a cancer, just the pre-cancerous stage. Pre-cancerous. It means if you don't remove it, so it will eventually turn to cancer. Okay. So then by cutting out 26 cm of the colon,
20.
that's fine, no? Huh?
20.
20 cm. 20 cm is fine. We have about 1 meter long of colon in every one of us, some even longer. So actually God knows that we don't have spare part. So everything they give us in extra. We got extra lengths of colon, extra lengths of small intestine, extra we got 2 hands, 2 eyes, and 2 legs and things like that. So the cutting out
Don't
20
have
cm
extra
actually
wife,
nothing,
okay?
So you are expected to resume a normal life.
Yeah,
You
I
don't need
think
to have any restriction diet or anything. Just that in general, for cancer patient, we usually advise patient to avoid sugars lah. Avoid
I
sugars
see.
because we know that cancer cell love sugar. So you must take away the things that cancer cell like and give them things that they don't like. For example, they don't like oxygen. So you must do more aerobic exercise, give them oxygen, also avoid giving them sugars lah.
Oh,
So
I see.
reduce in sugars, yeah, for cancers in general.
But actually, colon doesn't
Mm.
have any absorption function, right? Except for
Colon
fluid,
is mainly for water absorption
fluid
and
only,
little bit
right?
of
Not
sodium
for,
absorption lah.
yeah.
So mainly for water. So the main nutrient absorption is from the small intestine.
Okay, Dr.
Uh,
Siti asked, a lot of people like to take slimming coffee or detox. Can this lead to cancer? Oh, I have to.
Okay, so the slimming coffee or laxative that you of any fibers you buy over the counter. So we think that it also contains a little bit of laxative. So it may ease your symptom of constipation, but if your symptom of constipation is due to underlying colorectal cancers, it may delay your presentation to the doctors lah. So what our advice is, if you have symptoms, go for a scopes, have a peace of mind. Okay. If you don't have symptom, we also advise you to go for a scope at the age of 45. Okay. So whether it can cause cancer or not, I think if constipation more likely to cause cancer rather than non-constipation. So you take something detox to make you poop easier and every day. So it may reduce your chance of cancer. Of course, we don't have data on that. So
Oh, I see. So
no,
if you've
from the
got a good bowel
observation that
habit that is regular,
yes,
uh,
yes,
then
no,
it's more like less likely lah.
yeah, as we know, more than 50% of the cancer happen in the left-sided when the stool is solid and transits slower. So when you have constipation, so you have more contact with the toxic stool. Am I right? So if you can poop every day, of course, better. Otherwise, the toxin may be reabsorbed into our circulations, you
So
see.
a high fiber diet should be good.
Okay. Okay, so high fiber diet is the answer is true or false lah. So it's good in general, but not good in certain patients. Okay, as we know, our body have we have 3 trillions, 3 trillions of bacteria in the whole body, of which 95% of all these bacteria in the colorectal. I mean in the
Right.
our bowel lah. Okay, 95%, So and this bacteria also it will secrete some minerals and vitamin for us lah. So it will help with the fermentation of food and things like that. Okay. So when you what you call that?
Take the fiber.
Yeah. When you take the fiber, so for fiber, we have two types. We got this soluble fibers and insoluble fibers. So insoluble fiber is the one that make our stool bulky. So when the insoluble fiber make the stool bulky, so it will when the fiber increasing in volume, stool bigger, it stretch the colon, then the colon will have more peristalsis, move faster. Then the stool will go down faster. But sometimes the stool too big, it can cause anal fissure, tear in the anus. It can cause too much of straining to evacuate the stool, can cause hemorrhoid formation, hemorrhoid bleed,
Oh,
or blood clot in the
problem
hemorrhoid.
also.
Yeah, so it doesn't mean too much of vegetable is good. So sometimes patients say, oh, it's very good. So I myself alone can finish one whole plate of vegetables. I think
But they come
overdoing
with
is
two
not good.
problem. They come
Yeah.
with other color.
So they come with other problems. So because the fibers is indigestible, insoluble fiber is indigestible, it contribute to the ultimate size, especially when you drink less water. So the colon will absorb more water from the stool and the stool become bulky and big and hard. So it causes a lot of problems in the anus. So
Okay, I
so
cannot, it's very uncomfortable for me to talk about stool. I feel like
so
that's why I
so the
never.
fiber to certain patient is good, certain patient is not good.
Okay. So
Okay, in short,
Dr. Siti again, aspartame.
uh,
I don't know what is I don't know what is aspartame or aspartame. aspartame, I guess. Is aspartame carcinogenic? Does probiotic reduce the chances of colon? I think it's too random lah, these questions.
Oh, so okay, so talking about
Probiotics.
the probiotics, there's no data saying that probiotics can prevent cancers lah. No, no data on that probiotics can prevent colorectal cancer. So then aspartame, the one I think is a sweetener, is it?
I don't
think
know.
it's a sweetener in replacement for, it's a replacement sugar for diabetic patient. So
With no calories, and
I think so. So whether it can cause cancer, we don't know, but we know that it can cause some nerve problems.
oh,
All
really?
this sweetener can cause neurological problems.
I didn't
Can
know that.
damage the nerve.
Okay, Dr. Hui asked, which is quite a good question, because you see now every screening center does this CEA. So
The cancer marker.
yes, how do you manage middle-aged patients with elevated CEA and asymptomatic scope lah?
Okay. Okay, so yeah. So okay, so we have a lot of referral from our GP frontliner. Okay. So for elevated CA. So actually we don't recommend CA as a screening tool because when you have cancer, the CA can be normal, can be elevated. So having a normal CA doesn't mean you are not having cancer. So it can give you a false sense of security, or sometimes it can give you a false alarm. For example, smoker can have elevated CA up to 7. Okay, so this test is not cheap, and then it's not sensitive. That's why we don't recommend to be used in general. Just that the blood test package nowadays include everything lah. So if it is free, then it's all right lah. So otherwise, we don't recommend it as a screening tool lah. Okay, so when you have CA high, so that means we have 0 to 5 is normal range. So anything more than 5, we recommend you to go for colonoscopy lah. So no, CA high can be due to 2 type of causes. Benign causes, for example, any inflammation.
Hello, can you hear me? Can you hear me?
The cancer can be due to stomach cancer, can be due to pancreatic cancer, can be due to lung cancer. Also, CA can be high. So usually, managing all these patients with elevated CA. So first, we want to know whether patient is it a smoker. So smoker, we can accept up to CA up to 7. But then to be on the safe side, usually we ask them to do scopes. So as I told you, CA high can be coming from stomach cancers. Esophageal cancer also can. So usually we advise the patient to go for gastroscopy plus colonoscopy, and I will do the CT scan, the whole body lah, thorax, abdomen, pelvis, to make sure that patient have no lung cancers, no upper GI cancers, no pancreatic cancers, things like that. No? So we will screen up, because when we do scope, we can only see the inner lining of the GI tract. So outside the GI tract, organ like lungs, pancreas, we can't see. Okay. So usually what we do is we do upper lower scopes plus CT scan for elevated CA. Hello?
Yeah. Can you okay. No, sorry, I was I just realized. I'm so sorry.
No problem.
Okay, we won't take any more questions, but I just realized that those tuning in, we don't have QR code for CPD points anymore.
Oh.
So because yeah, MMA doesn't give QR code with anymore to scan. So maybe you
hello?
Can you hear me?
Yeah, the line broke off.
Yeah, sorry. Can you all message me for okay, give me, this is my number, give the name, IC, MMC, mobile number, and email. Then we will send it manually. Okay?
Okay.
Yeah, you can also give me all that. We will give it to you 5 points as a speaker.
Oh, thank you. Yeah.
Okay.
My point already exceeded lah.
Okay, then no need lah. Waste our time. Thank you very much. Okay.
Yeah.
For the comprehensive talk of colorectal cancer. And I think in view of the the prevalence and the fact that it's getting younger and younger, I
Yeah.
think it is worthwhile to think of screening. And screening would mean a colonoscopy rather than just a simple
The
CA.
line broke.
Oh, again.
Ah.
Okay, sorry.
Oh, no, I can hear you already.
No, hold on. Okay, now you can hear me? Okay, so basically the take-home message is, of course, to screen and screen younger people. Can you hear me?
Hello?
Can you hear me? Can you hear me?
No, I can hear you.
Sorry.
Yeah.
Basically, to screen and to screen younger people, to take all symptoms seriously. As much as I don't like to speak about stool, it is important to just have a look at your stool when you poop. I think it's really a simple measure. Okay, it's a very simple measure. It is very easy to have a look. And sometimes you do see bleeding. Of course, most times it's simple things like hemorrhoids, but don't take it lightly. Yeah. Okay.
Yeah, fully agree with you, Dr. Betty.
Yeah. Just call me Betty, lah, please. And yeah, I think simple things, to really to notice your own body. I mean, if you're a person who bowel habit is every day, and then you don't open bowel for 3-4 days, don't take it lightly. Yeah.
Yeah. Okay.
Okay, thank you very much, Ken. I see you
everyone, for your
tomorrow.
time.
I'm finally
Okay,
going
have a
back
nice
to work.
evening, everyone.
Bye.
Yeah, bye. Goodbye.
Join us next week. Join us next week. And
Yeah, what's the topic next week?
I can't remember. I can't remember. I think it's actually Margaret. Margaret is doing burns. Okay, bye guys. Bye.
Oh, I
Okay,
see.
see you again. Bye.
Okay, bye.
Hold on, I'm going to
Bye.
stop.